Shona, thank you very much for joining us for our May webinar at NASGP, and you're going to be talking about faster, better brain tumour diagnosis in general practice. So over to you.
So thank you so much for inviting me. The caveat to this faster, better diagnosis is that it very much is not even in its infancy, it's in its embryonic stage. So this is a brand new project. We're about 6 weeks in. And when Jacqueline asked if we would come and talk to you, we thought, what a better way of doing that than talking you through our project that we want to do and seeing if anybody would like to join us, be part of this, or indeed just offer some constructive criticism. We're open to everything. You know, we're not precious at all. So who are we as a charity? We are the leading brain tumour charity dedicated to brain tumours in the UK. So we have got other wonderful charities such as Brain Trust, Brain Tumour Research, Brain Tumour Support as the major charities, but they each do very different things. And we are the only one in the UK that does research. We support adults, we support children and families, we support young adults. We have a policy dedicated team, we have a data insight team. We're not huge, we're only 120 strong at the moment, but we cover everything. And we have the mantra that we want to aim to double survival and halve the harm. And I'll cover halving the harm in this presentation throughout. But basically what we want to do is to get patients in front of the neurosurgical team to help reduce the deficits caused by having a brain tumour. I've already alluded to the fact we have a research team, and over the last 6 years, we've put 38 million into research. So we are a research charity primarily, but we only research primary brain tumours. We don't research neurofibromatosis 1 or 2, and we don't research metastatic disease. The other thing we do around that support is we have online support forums. So we have the usual cohort of Facebook, TikTok, Instagram, Twitter, or X, and Health Unlocked. And on Facebook, we've got 24,000 unique users. So we have a closed parents group, we have a closed carers group, we have a closed young carers group, which I think is really important, and we have a closed young adults group. And one of the other things that we've done, and we're quite proud of, is we worked in conjunction with the Royal College of Paediatric and Child Health and David Walker, who's a professor of neurosurgery at Nottingham, and we developed the Head Smart campaign. But I'm just going to talk about the new Better Safe and Tumour right at the very end. But we've helped reduce waiting times in the last 12 years from around about 13 weeks to about 6 weeks. Obviously, we'd love to get that lower. That is a work in progress. I went too far. So who are we? So one of my colleagues, Lorcan, some of you may have seen some of his talks. He's an optometrist by background. He does a lot of talks on papilledema. He goes to all the major high street optical chains, and over the last 4 years has, I think his figures is something like 8,700 optometrists he's trained in looking for those early signs and symptoms, such as papilledema, pseudopapilledema. And he does that quite beautifully. So if you would like a talk from Lorcan on the signs and symptoms of papilledema, then if you Google LinkedIn him, it is something that he's always running with the local optical councils, and it may be that you can jump into one of his chats. I've grown my team in the last year. So my team, I've now got a paediatric healthcare oncology nurse, and I have got Molly, who is a therapeutic radiographer by background, which is brilliant because it covers those paediatric pathways and therapeutic AHP pathways. And I'm the healthcare engagement manager, and I've been here for 7 years, and I'm an adult nurse by background in oncology, gerontology, and a couple of other wee bits. And I also then went into lecturing prior to coming to work at the Brain Tumour Charity, and I've been here for 7 years. I'm sure some of you are aware of the statistics around brain tumours, so I'm not going to linger too long. I'm just going to quickly cover them through. It is statistically the biggest killer of under 40s. We have around about 12,000 patients a year diagnosed, and around 6,000 will lose their lives. So when you look at the years life lost, you're looking of a reduction of around 27 years knocked off life expectancy, and our 5-year survival is just 12%, which is poor. We are part of the Less Survivable Cancers Task Force. I'm on the Less Survivable Cancers Task Force for Scotland Committee, and we know we're not the worst. Pancreatic UK tell us, for example, that pancreatic cancer has got a 5-year survival rate of just 1%. So, you know, there are 6 of us within the less survivable cancers, but each of whom cancer groups have got horrific long-term survival rates. One of the gateway pieces, so as I said, the project we're doing is quite new, it's in its infancy. So we've been doing a lot of desk research over the last 4 to 6 weeks, looking at NICE, looking at the ICBs, the IPSs. We've been, you know, doing literature reviews, and I came across this one, and I didn't know we'd funded it. We funded it in 2000, part funded it in 2019, and I've put the link at the bottom. And some of the people on there are leading professors of neurosurgery across the UK. And what they wanted to look at was what missed opportunities are there when patients first present in primary care. So one of the limitations of this study is I think they only had something like 45 participants, which for a cohort study is really quite small. But of the cohort that they did interview, over 50% of the patients were attended and then diagnosed via A&E, which is a huge number. And when you look at the 2-week referral, which you all do into neurology, only 1% of all brain cancer patients were diagnosed through that 2-week wait, which is a really surprisingly small number. But one of the things they did look at was they looked at the classic, you know, you've got a headache, you've got this. What does that look like? Is that a brain tumour? Is this reoccurring headache a brain tumour? But actually, when you read the paper, and I suggest you do because it's quite interesting, is that the patients were coming to them with very vague symptoms. So quite anomalous ones. They weren't headache plus. They were that they felt spacey. They felt as though there was something else going on and they couldn't quite put their fingers on it. And the patients would say, I just don't feel right. So when you look at the classic positive predictive values and the classic combinations, they weren't necessarily presenting with these initially. They were presenting with, like I say, these really vague ones. So when you consider that the positive predictive value thresholds are 3%, and then you look up that list there underneath, the ones for brain tumours are actually really high above the 3% threshold. And obviously, because we have devolved nations, when you look at the Scottish suspected cancer guidelines, they stipulate that any new onset seizure has a 2 to 6% probability of having a brain tumour, which raises to 10% if it's a consecutive seizure, and then not regaining consciousness in between, you know, like the 5-minute, or they're having collective seizures, cluster seizures, one after the other. So what we want to look at is how can we put guidelines forward if actually one research is saying one thing and the PPVs are saying something different. So as you can see, we have got an uphill task in front of us. I'm not going to go into our improving brain tumour care surveys in great detail because they are huge and they cover diagnosis, neurosurgery, chemoradiology, living with, and palliative end of life. But the results you're going to see in a minute have been done, are an interim result, and they will close in September 2024. So our surveys have been developed in direct response to the National Cancer Patient Experience Surveys. And one of the problems with NC pairs is, as I'm sure you know, they're retrospective. So they come out a year afterwards, and they're something like 70 pages long. And when you look at the tables when they come out in July, August, whenever it is they're going to come out this year, and you look at brain, it's brain and central nervous system. So we're not even our own category. We're in with central nervous system disorders. And if you go to some of the major neuroscience centres like King's or Addenbrooke's or the Walton Centre, they will have 0 across the board. So the patient voice wasn't being heard within neuro-oncology. So we set up our own. And we do this by emailing and sending out postcards to the main neuroscience centres. Patients can do it online, they can do it on their phone. It's based on Qualtrics so that we can take data and use it in research. They are also used as part of the Tessagile Centres of Excellence designation programmes. And they have been going for 4 years now. And the third tranche is about to start this year. And the neuroscience centres are filling in their forms as we speak. So bear in mind this interim report is only for a year, but the results are from just over 1,300 people. And when you look at the diagnosis point, 41% of people visited their GP 3 or more times, and 43% were told they had a brain tumour by an A&E doctor. So if I cast your mind back to the 2019 research paper, that said over 50% were told by an A&E doctor. So that number has dropped, which is brilliant. But it's still not dropped quite enough for what we want to do, which is something, again, we're looking at what do we need to do to ensure we can do that. So we all sat around a table and we thought, what can we do? And we have loosely named it Faster Better. And our aims are, we want to understand and really improve that pathway for adults and children who are being diagnosed with a primary brain tumour in the UK. So we want to go back to basics. We want to go from the point that they first present to you as GPs to end of life palliative care. So everything in between. And we want to understand, what are the barriers? What works really, really well? What is it that holds you back? So is it that you do your 2-week referral into neurology? And as some GPs have told me over the last, I went to the RCGP conference in October, November, whenever it was. And a few of the GPs I was talking to say that their 2-week referrals get bounced back, that they will send people for a scan, it gets bounced back. So it's this kind of information we need to know. What is it that's getting bounced back? Is it that the form hasn't got enough detail? Is it the form isn't right? Does the form need changing? We're looking at this not just as a nice thing to do as a charity, but to challenge directly. And one of the things we're looking to do is to have a neuro-oncology pathway, the same as stroke have their pathway and headache has their pathway. There is no national pathway for neuro-oncology in the UK. So our policy team are working on this project from a very policy-driven, nice Department of Health point of view. And we are looking at it as hearing your voice and what do we need to do from that point. So our Head Smart campaign, which I briefly touched on earlier, was for paediatric. But what we've done is we've added in adult, and we did that in 2022. And right at the end of the presentation, I've got a screenshot of the cards that we hand out. But what we want to do is we want you to tell us what resources haven't you got? So we're also talking to EMIS and looking at what can we do with EMIS when you're actually in surgeries. What can we do that will engage other support professionals? We're looking to pilot this in 1 or 2 geographical areas. We haven't got that far yet. This is just our aims at this current point in time. And we're going to have to use scanning as the proxy for brain tumour diagnosis, because this is the only current means of initially doing this at the moment, and is what NICE and in England and Ireland, England and Wales say, and Scotland have slightly different guidance. But the scanning is the proxy for brain tumour diagnosis. And I was talking to a neurosurgeon just recently who said, with the best will in the world, even your most experienced neurosurgeon would not be able to do a detailed patient history and walk away with no other tests and go, that person has a brain tumour. So we know that it's not easy, but we also need to try and figure out how can we make it easier, or how do we make the process simpler, which is where you all come in. So this is our rough timeline. We're scoping it at the moment between now and September. We would love to do a GP working group and expert advisors. We've got a couple of neurosurgeons who have already said yes, got some radiographers who have already said yes. So what we need are some wonderfully wonderful GPs like yourselves that would be interested in joining us on this working group and talking through, you know, what's missing, what do we need to do. In September, we'll make a decision point, go or no go. And if it's go, then we'll make the high level business case to get resources, start to do the pilot, help GPs become more aware, remove the barriers, etc., etc. Next, the pilot will be October this year to July 2025. We think we need to do probably 2 or 3 areas to band it across the UK. So geography was never my strong point at school. So let's just say top, middle, bottom, you know, sort of that M62 down to Birmingham corridor, something pan-London across to the home counties, and then something Scotland as well, that covers, you know, Wales and Ireland. And then we would evaluate that. We'd take some time, run the data, run the figures, evaluate that, and then make the business case for a wider rollout. If all of this works, we will then repeat this in November 2025 with A&E doctors, because again, you know, whether you take that greater than 50% or 43% or somewhere in between, people are still going to A&E. And when we look at the figures for people going to A&E, they're going to A&E query cause. So they're going in with collapse query cause, seizure query cause, stroke, and then they're put on those pathways, they're scanned, and then it turns out they have a brain tumour. So we need to reduce the amount of people being blue lighted into A&E with collapse query cause and get them on the pathways much sooner. Why do we need to do this? Well, as I've alluded to with those deficits, I'm very lucky and I work with very closely with nearly all 30 of the neuroscience centres, and I've built up an amazing network over the last 7 years. And every neurosurgeon, when I talk to them about this, tells me that if they were able to have the patient in front of them sooner, they are able to do a greater debulk because the tumour is smaller and they are leaving the patient with fewer side effects from that operation. Their outcomes are considerably better. They have fewer long-term side effects. It doesn't negate all of them, but we know that many of our community are living with huge deficits. And whether that's a sensory deficit or an ambulatory or cognitive, they are left with something. So if that tumour is taken out at a much earlier stage, we can negate those deficits down. One of the things our Improving Brain Tumour Care surveys, we've got verbatim, and I do the verbatim because I'm not a data analyst. And when you read the verbatim, quite a lot of people are angry because they didn't have more choice in their treatment. They didn't have access to trials. They weren't told they were dying. They weren't told that this was a life-limiting condition for many of them. So we want to have a faster diagnosis so that these patients have more choice in their treatment, that more novel treatments are open to them at an earlier stage, that they can have their genomics mapped, that they can have their tumours flash frozen, rather than doing that scan and looking that they're just going to go straight onto a palliative pathway. It also then has a reduction in the emotional impact. You're obviously never going to take away from that emotional impact when you're telling somebody they've got a life-limiting condition. And that life-limiting condition following surgery may leave them with a considerable deficit. But we can help lessen that. And as I just kind of said a minute ago, that acceptance and adjustment, I know, having been working in oncology as an oncology nurse, you will always get patients that don't accept. You will always get patients that find it really difficult to adjust. But there are those that are given enough time that they will be able to find some acceptance in their diagnosis and be able to adjust accordingly, and their families will have more time to adjust to the inevitable. Now, obviously not every brain tumour comes with a terminal diagnosis, but even the low grade tumours can have a severe impact for the rest of the life course, whether that's with fatigue or with seizures. You know, it isn't as simple as you have a low grade, I've taken it out, therefore you're going to be fine. So this is why we want to do this faster diagnosis piece. One of the things is our surveys are not validated. It is something that we are looking to do for our surveys. But so far, when we've done all of our desk research, we haven't found any validated data for the clinical interval. So from the point that they step in front of you as GPs to the point that they have that appointment with the neurosurgeon following an MRI scan, we don't have that. So it's something that our CEO has said that maybe we could consider doing a data piece around that and doing it retrospectively. So let's look at when they go in for the MRI and work backwards. So we're using the proxy that it's MRI plus a week for reporting in front of the neurosurgeon. But our surveys are saying that the clinical interval is too long. So it's 26% for adults and 41% for pediatric patients, that it's taking over 3 months. That's a long time when you are going to, you know, if you've got a DIPG, now a midline glioma, or you've got a glioblastoma, those have got really short trajectories. You're looking for both of those anywhere between 6 to 18 months. Well, if you're waiting for 3 months, you know, that's too long a time. We need to get that number down. We've already touched on this a little bit. Too few visit the GP with symptoms, and when they do go, they're very vague, very anomalous. So the numbers are quite high. 60 and 64% will visit a GP at some point during en route to diagnosis. And when you look at our surveys, it's around about 50% of those adults who are still alive after 18 months visited, 76% of those visited their GP. Sorry, get that right, Shona. 50% visited their GP, 76% of all cancer patients visited their GP. And the rapid cancer diagnosis data set which we've been trawling through suggests that it's around about 18% of all diagnoses of all cancers are directly attributable to a GP referral. So again, it's understanding what are those barriers. Is it because that people aren't coming with symptoms that are easily discernible? Are people not coming to GPs at all? Are they writing off their symptoms? You know, I've got hay fever at the moment. I know I've got hay fever, and I know that's why I've got a headache and my throat is sore. But if it was the middle of winter, would I be just boshing it off that I've got a cold or there's something else going on? So we need to be working with the general public, but also working on how can we get patients and GPs talking to each other with more clarity. Diagnosis isn't fast currently. Again, we're looking at that interval. So what we want to do is we want to have a look at that piece where we're looking at the MRI and working backwards to when was the first point that they visited a GP. We know that the surveys are telling us that it's 3 or more times, but what is that interval between visits? Is it that somebody came in on the 1st of April, the 10th of April and the 21st of April, or has somebody come in on the 1st of April, the 3rd of June and the 4th of September? We don't know. We don't have that data. We don't know what those intervals are, and it's something that we really need to look at, because if we're going to do this, we need to do it properly, and if we're going to have impact, then we have to have all of those numbers. So as you can see, this Faster Better isn't a small project, and it's going to take quite a lot of time for us to get all these figures and these numbers in. Yesterday, I literally did this slide this morning. So yesterday I was in a meeting with Stuart Smith, who's a really lovely neurosurgeon in Nottingham. And they've done something quite novel in Nottingham in that they have completely and totally abolished the 2-week neurology wait. They don't have it now. So they did a pilot last year. They worked in conjunction with local GPs. And what they found was when they did the research behind this was that 95% of all patients who presented at the 2-week neurology clinic went on to have an MRI. So they sat down and thought, well, why are we doing that? Why are we making GPs do a 2-week referral into neurology that neurology is already going to send them to an MRI? Why don't we just get rid of our neurology clinic, the 2-week wait clinic? So they have. They've completely got rid of it at Queen's Medical. And now everybody goes in for a 2-week neurology MRI. So they go in for the MRI and not to see the neurologist. And what they found, and they have written this up, it is a paper, but it isn't published. So Stuart was very kind to give us some rough numbers for you today. 75% on their MRI, it was structurally normal. There was nothing. 10 to 15% showed other conditions that had not been diagnosed. So MS, stroke, vasculitis, there was a few other bits in there as well. Interestingly, from a brain tumour point of view, 5% had already got brain mets from an unknown primary. So they were then referred into the rapid diagnostic clinic and other tests were carried out. And then they went to wherever the primary was. And only 5% were primary brain tumours. It's been so successful that what they are going to do is Leicester, who feed into Nottingham for neurosurgery, are just about to pilot a similar scheme in Leicestershire. Derby are in the middle of piloting it at the moment. Again, they feed into Nottingham for neurosurgery. And Sherwood Forest, who feed into Trust, who feed into Nottingham for surgery, are also going to pilot it. So in a year's time, it will be really interesting to look at these figures again and to see, does the abolishment of a 2-week neurology clinic to send them in for an MRI reduce those deficits, get patients in front of neurosurgeons faster, and equally look at the bonus. It is picking up MS early, vasculitis early. It's got those brain mets for an unknown primary early, hopefully. So that was a really interesting piece of work. So everything that we thought we were going to do on our timeline, after talking to Stuart, we're now thinking, and apologies, this is hot off the press. We haven't had a great discussion about this. Do we need to rethink what we're going to do on the project? Do we carry on with what we're doing? Do we need to look at, approaching NICE about this abolishment of a 2-week neurology wait? And if the 95% in Nottingham is indicative across the country, do we do a push for a 2-week MRI rather than neurology? I don't know. So I thought I'd just tell you quickly about 2 new diagnostic tools that are in the offing at the moment, which again may make your lives much simpler with referrals. So Paul Brennan, I was very lucky when I started 7 years ago to go up and meet Paul, and he was doing a talk to Lothian GPs, and he was doing a talk around headache first, what comes second. So when patients were presenting with a headache, what else was there? He did a verbal acuity test and looked at other things, and what they had was open access to CT scanning. So what Paul's now looking at and is working with DX Cover on is the use of a simple blood test. And this project was started in 2019. So it's a blood test taken, and then what happens is they scan with an infrared, and it creates a biosignature. They then feed that biosignature into an AI program, and the AI program measures against all the other signatures that it's had uploaded, and then it will flag all those that have match a positive brain tumor diagnosis previously. So it's all very, very clever. I was at the CCLG conference last week where they were talking about AI. It's just amazing what AI can do now. So when you look at the pilot, they did 400 patients referred to scanning, 40 were subsequently found to have a brain tumour. The test showed 82% were found to have a brain tumour, which is amazing, and 84% didn't. So when you look at that, again, it's quite small numbers. They've decided to take this, and they are currently working in different nations around Europe, and they're looking for 2,220 patients. They've renamed it Embrace. It's current at the moment. and they will publish within the next year, I think. And the word I heard on Tuesday was that they think that the blood test could be ready for rollout in 18 months to 24, which would be amazing. Obviously, patients would still need an MRI scan, but this would be a really simple way of doing that screening diagnostics. So we'll have to see. And then the other one, which is really interesting, is Petra Hammerlich. So she is the chair of neurosurgery at Manchester. And we've funded her as a charity a little under 1.4 million over the next 5 years. And she's looking at using tears to diagnose brain tumours, because they already, and I didn't know this, they already do this for ocular diseases. So for those that have got suspected retinopathy due to diabetes, allergies. So she's looking at the tear proteins to see if it can differentiate anything from for brain cancer patients. And so far, her test is 99% accuracy, which is fascinating. She is now initiating that across the UK to validate. And again, that's a work in process. But when you look at these two new tools, they could be game changing. So when we're looking at this faster, better diagnosis, we are doing this with these in mind, because if we're going to push for an abolishment of the 2-week neurology wait for MRI instead, but you've got these potentially new diagnostic tools coming out, what, you know, could they go in conjunction? Could we get NICE to approve? You know, the pot of gold at the end of the rainbow could be amazing, but equally we will just have to see. This is the NHS we're talking about. So our potential next steps and desired outcomes are that we would love to see an increase in reported awareness from GPs of brain tumour signs and symptoms. We would love to see that the referral pushback is decreasing, and that the confidence for all of you as GPs is increasing in doing that referring. And again, that's something we need to work with to the neuroscience centres. Could we get the 2-week MRI brought in as opposed to 2-week neurology, and that 95% then going for an MRI scan, which would then see the increase in GP MRI referrals? So I've written down a couple of numbers here that I didn't put on the slides. In last year, my directors found a document that says there were 882,000 brain MRIs. Of those, 115,000 were GP direct referrals for all brain, obviously not just for brain cancer. Can we drive that number up? You know, if the Stuart Smith, Nottingham, Leicestershire, Derby pilot works, could we drive that up? And can we decrease the amount of times that GPs are having patients come into them with these anomalous signs and symptoms with Paul Brennan and that team's blood test, or with Petra Hammerlich's eye fluid test? You know, it's just really exciting stuff. So our impact measures, we are looking at how do we best measure the impact of improving GP presentation? How do we make it accessible? How do we make it reliable? How can we do this quick to change? And how quick is that each potential measure? With these new exciting innovations coming, you know, how are we going to measure the impact of those? Because we haven't even begun to look at those. So we may look at the actual GP A&E visits prior to diagnosis. So as we've already discussed, our surveys are saying it's around about 43%. Well, can we drop that? Can we drop the amount of people that are blue lighted to A&E, or that are presenting to A&E with, you know, ongoing cluster headaches? I know thunderclap headaches are treated slightly differently, but, you know, is there something we can do along those lines? And we also then need to measure what is that actual clinical interval. So that is a really key measure. How do we measure the point when they first walk into your consulting rooms to being on an MRI and in front of an MDT? What does that interval look like, and how can we change that? So we have got lots of things we want to do, And as I'm sure you can appreciate, as I've just talked about for the last 25 minutes, it's massive. The project is quite large. How can you help us? Email me. I would love to hear if you think that we are completely barking and that, you know, everything that we want to do is, you know, we've got more chance of finding a unicorn. I'm open to constructive criticism, as is my director. But what would facilitate faster, better diagnosis of brain tumour patients presenting to GPs? Only you can tell us that. Only you can tell us what barriers you face. What are those barriers with those neurology 2-week waits, or those access into MRI or CT scanning? Are they that the forms are too convoluted? Is it that you know, your local MRI or CT scanning is overwhelmed? We appreciate that there may not be enough physical slots in MRI scanning, that we already know there aren't enough radiologists to read the scans. We're aware of that. It's a piece of work that the Tessa Jowell Centres of Excellence are also looking at. But without your valuable input, and it is completely valuable, we won't know, because we're not GPs, and the GPs that volunteer that we know are already, if you want, team brain tumour charity. But we're open to criticism. We're open for anything that you think would be valuable for us. And I don't care if my inbox has got 200 emails. If it helps us to help you and our patient group, then please just do send those emails in. As I quickly said, these are the cards for our early diagnosis signs and symptoms campaign. We have got more heads. We've got a baby head. We've got a young child head. We have a middle-aged chap head. And the reason they were done like this is that those heads are interchangeable. So anybody in any country can put their culturally appropriate head on that card. And we did that deliberately because we are global. We do support people globally. And they're a trifold card. And when you open them up, you can see there. So the first three are from our Head Smart campaign that we did in conjunction with David Walker and the College of Paediatric Child Health. And then the adult one is the one that we put in 2 years ago when we renamed it Better Safe Than Tumour. So we know as adults, we are not completely brilliant at always recognising when we don't feel very well. But we're also very aware that what we don't want to do is then have 8 million people all rushing to their GP with a headache thinking they've got a brain tumour. So unfortunately, the bottom bit of the card didn't scan, but underneath there are caveats for when you should go to A&E, when you should go to your GP, and when perhaps you should go to an optician. I really do appreciate your time, and I know that was a real whistle-stop tour of our plans, what we want to do. We don't believe in that, you know, if you don't aim for the stars, where are you going to go? So we firmly believe that this will work. We think we're realistic. We know it will take some time. But thank you so much for having me today. I'm going to send Ellie the slides so that you have them. And obviously this is recorded, so you can have access to my email should you wish to ask anything off presentation. But thank you so much for having me.
Thank you very much for the talk. It was really informative and just packed full of references as well. So lots of things for people to look up. We've got a little bit of time since it's 1:45 for Q&A in case anybody had anything they wanted to contribute. Shelley, thank you for your clap emoji. This is a great time to ask Shona a bit more about how she's found, for example, those that work going on in Manchester and Edinburgh. You know, how are you connected to those academics? How did you hear about that work?
So Paul Brennan is a long-term fan, if you like, of the Brain Tumour Charity, and we funded some of his work previously. So we have research rounds, and when the research rounds open, there's certain areas that we look at. So the next research round will be quality of life, and that will open next year, and they're looking at that. So Paul Brennan is, you know, I'm not quite his number one fan, but maybe number two or three. I think he's brilliant. I love his insights. I love what he's trying to do. And I think maybe that comes from the fact that he was the first neurosurgeon I met when I started in this role. I'd only been in post 2 weeks, I think. And the GP reception in that room in Edinburgh, those 52 GPs that were sat there, and the fact that they had open access scanning and somebody was listening to them, for me, was inordinately valuable. And listening to how Paul wanted to do things from a neurosurgical point of view, and linking in with those GPs and having that continuity on the pathway was something that we hadn't seen before. I actually don't know Petra. I've never met Petra, but I know the old CEO at the Brain Tumour Charity and our old chief scientific officer who's gone on to work for LifeArc. Both completely rate Petra and her work. And again, who would have thought something as simple as testing tear fluid could potentially have something game-changing, like that early diagnosis. Blood tests can already look at in depth at cancer cells floating around, but we know that they've got the blood-brain barrier. So using the tears, I mean, that again, that's such a novel idea. And so far, I mean, it's showing that it works, but it'll be really interesting to see what that longitudinal study looks like when it comes to the end. Has it, these other areas that they've gone to, has it had the same results? Have they been the same? And then Stuart Smith's work, I think that's the game changer. For me, that's the game changer. Like I say, if 95% of all 2-week neurology waits end up having an MRI, why would you not directly refer in the first place and abolish that 2-week neurology wait clinic and get them in front of a scanner, which then puts them in front of the MDT, or a letter comes back to the GP saying, actually, it's a structurally sound MRI. We have got a meeting booked in with the lead GP on that project in the next couple of weeks to find out how he found it from a GP perspective and referring those patients in. So there's a lot of exciting work. And when we started this project, I don't think we realised how leggy it would grow, and quite how quickly in the last 6 weeks it would grow, and what the impact potentially could be. And we haven't finished talking to everybody yet.
Super. Thank you. That's very detailed, very helpful thinking about what's coming up in the next 12 months as well. Yeah, Shona, thank you again for the talk. It's super informative, and we're looking forward to hosting the slides and the video on our site so everyone can see what we talked about today.
You're more than welcome. It was a pleasure to do it.
Thanks, everybody, and thank you for giving up your lunch hour to join us.